Hello friends, we will see in this topic colorectal cancer screening. Colorectal cancer screening, aim of the screen, why we want to screen and whom we will screen. The aim of the screening to detect the pre-cancerous condition in healthy population. Mind it, the screening is applied not for symptomatic patient, it is asymptomatic healthy patient we do screening as well as very early stage malignancy detection, which can be treated by clearly curative intention. That's the aim of the screening, to detect the precancerous condition in healthy asymptomatic patient, or it is a very early stage which can be clearly treated by curative intention. What we do, FOBT, that is fecal occult blood test, by doing stool guaiac test, guaiac test. It is based on pseudoperoxidase activity of heme in the blood. What they do is they take a stool sample, they test in the lab. This test FOBT based on the pseudoperoxidase activity. As we need a strict dietary adjustment before collecting stool sample. At least 2 ml of blood. If we want positive FOBT, at least 2 ml of blood is needed to become FOBT positive. FOBT reduces mortality of colorectal cancer by 15%. FIT, this is one of the better fecal test for colorectal cancer screening. It is superior to FOBT with respect to detection rate and positive predictive value of adenoma in cancer. It mainly depends upon detection of human globulin within the hemoglobin. If we are hemoglobin is in the stool, that globulin component, FOBT based on pseudoperoxidase activity, FIT based on human globulin without the HB. 95% overall accuracy for colorectal cancer detection, lower sensitivity in adenoma detection, only 28%. So as compared to FOBT, FIT test, which is the better fecal test for identifying or utilized in screening program of colorectal cancer. Next comes the flexible sigmoidoscopy. Standard sigmoidoscope length is 60 centimeter length and minimum 40 centimeter has to be in advance in a colon in order to minimize risk of missing the. If we want to do flexible sigmoidoscopy, means we are taking the same colonoscope, passing up to the minimum 40 centimeter we have to pass, so that distal malignancy pertaining to your rectum, sigmoid colon, descending colon should not be missed. The intention of doing sigmoidoscopy, we have to screen left-sided colon. We should not miss the left-sided colonic malignancy. Risk of perforation with flexible sigmoidoscopy is 0.02%. About 40% of patients located proximal to the sigmoid colon will not be seen on flexible sigmoidoscopy. CT cologram or virtual colonoscopy. Virtual colonoscopy, it is a colonoscopy. We are having some patient where we can't do a colonoscopy. We want to detect adenoma. Someone is not willing for colonoscopy, someone is not fit for colonoscopy. In those patients, we can do CT colography or virtual colonoscopy. This CT colography comparable to optical colonoscopy, detection rates are more than 95% of cancer, 90 to 95% if it is more than 1 centimeter of adenomas, 80 to 90% if adenoma more than 6 mm. Indication of colonoscopy after CT cologram. If we are doing virtual colonoscopy, when we need a colonoscopy, actually CT colonoscopy only diagnose, it's not therapeutic. If we are having colonoscopy, we can put the colonoscope, see the adenoma, we can take out the adenoma and test it whether it is high grade, low grade, malignance, or it is a stage 4 Haggitt's classification. We can do that, but in CT cologram we can't do that. So in which condition we need a colonoscopy after CT colography? Then if the one or more polyp more than 1 centimeter, we have to do the colonoscopy. 3 or more, if more than 6 mm, we need a colonoscopy. Should be referred to subsequent colonoscopy and polypectomy. If more than 1 centimeter polyp, even if it is 1, we have to do the colonoscopy. If it is more than 5 mm, less than 1 centimeter, 3 or more polyp, we have to do this colonoscopy and do the polypectomy and get the biopsy done. Colonoscopy, missing rate of colonoscopy more than 1 centimeter is vary from 2 to 12%. Miss rate of cancer reported to be approximately 3% of overall. 3% it can miss the cancer in colonoscopy also. Proximally, if it is lesion, 6% can be missed on colonoscopy. The acceptable rate of incomplete colonoscopy means complete colonoscopy is colonoscope is going from the anus, rectum, colon and doing the intubation of the ileum, means we are going into the distal ileum, terminal ileum. The acceptable incomplete colonoscopy, that is without cecal intubation, is less than 5% in screening, means if the screening has been done and out of 100 more than 5 patients some endoscopist not able to intubate, means that is not good screening. In screening we have to intubate the ileum. If less than 5%, there should not be. Overall 10% overall. Complication following colonoscopy, perforation in colonoscopy is rare. It is 0.04% in screening, 0.07% with polypectomy. Polypectomy bleeding, 0.27% for screening, 0.5% for polypectomy. Post-polypectomy syndrome. What is this syndrome? It is what has been done is for removing the polyp, we do cautery burn. Because of cautery burn, we get localized peritonitis. So without definitive evidence of perforation, there is localized peritonitis, is give peritonitis features. Risk of post-polypectomy syndrome is 0.003 to 0.1%. Most common bleeding site after colonoscopic polypectomy is stalk of the polyp. Most common site of perforation in colonoscopy is sigmoid colon. Perforation can be caused by excessive air pressure, tearing of anti-mesenteric border of the colon. At the site of electrocautery application, there may be a perforation. Remember that sigmoidoscopic perforation versus than the colonoscopic perforation. Why I am telling this thing is because the colonoscopy, we do whole bowel preparation and put the colonoscope. Even if there is a perforation, fecal contamination is less. But if it is a sigmoidoscope, we do the sigmoidoscope usually done in unprepared bowel. The problem of sigmoidoscopic perforation will be worse because unprepared bowel, fecal contamination into the peritoneum will be high. These are the worst. Routine screening of colorectal cancer recommended. Routine colorectal cancer at the beginning. Screening protocol. How is the screening protocol? Begin at the age of 50, both men and women. Average risk means routine screening should be started at 50, which has been done all across the world. At average risk candidate, colorectal cancer means average risk is no family history of colorectal cancer, no personal history of IBD or cancer, asymptomatic patient, asymptomatic without family history, without history of IBD, without high risk history. These are the average risk. Patient, average risk patient, what is the colonoscopy timing? Colonoscopy should be started, screening should be started at a 50 year. If we are doing colonoscopy, it should be 50 year followed by next colonoscopy, usually required 10 year later. If we are doing virtual colonoscopy is as not good as the colonoscopy. If you are planning for virtual colonoscopy, then every 5 yearly you should do. If it is sigmoidoscopy only we are doing, every 5 yearly we should do. Double contrast barium if we are doing, it should be done every 5 yearly. Stool test, if it is a stool DNA we are doing every 3 yearly. If it is a FOBT or FIT we are doing every yearly. So very clear, if the patient is average risk, means no family history of colorectal cancer, no personal history of IBD or cancer or adenoma, and he is not having any symptom. In those patients, screening of colorectal cancer means colorectal cancer whether presence or not, we want to screen in normal individual. That should start at 50. If suppose we are having screening modality colonoscopy, second modality will be CT cologram or sigmoid colonoscopy or double contrast barium enema. Third method is a stool DNA. Fourth method is a fecal occult blood or fecal fit test. If we are doing the fecal occult blood or fit test, we should do every yearly. If at any point of time, if we are having a positive FOBT or FIT, patient should be subjected to colonoscopy. If we choose that stool DNA we want to do as a screening modality, some patient wants stool DNA, then sensitivity of stool DNA is better than the FIT or FOBT. But if we are following stool DNA, every 3 yearly we need a screening after 50. If suppose person chooses double contrast barium enema or a sigmoidoscope or CT cologram, every yearly that has to be repeated. If person chooses colonoscopy, which is the best modality for screening, more than 50 year age in a asymptomatic average risk patient, then we have to do repeat colonoscopy every 10 yearly till 75 or 80, that we will see later slide. Individual at high risk of colorectal cancer. Who is a high risk? The personal history of adenoma, colon cancer or IBD is a high risk. The significant family history of colorectal cancer or polyp is a high risk. Inherited cancer syndromes such as 5 to 10% of all colorectal cancer inherited will have FAP 1%, HNPCs is most common 3 to 5%, and other syndrome. These are the high risk patients. Personal history of adenoma and colon cancer or IBD, significant family history of colorectal cancer or polyp, inherited syndromes such as 5 to 10% of all colorectal cancer, FAP is 1%, HNPCs is 3 to 5%, or other syndrome. These are high risk patients. In high risk, protocol is little bit different. The screening guideline for an individual at an increased risk based on family history. If family history of colorectal cancer is there, then whether he belongs to first degree relative before the age of 60, two or more first degree relative. First degree relative is age less than 60, but two or more first degree relative are there. Then we need to start at 40 but repeat every 5 yearly. If suppose first degree relative is more than older than 60, two or more second degree relative, in those cases we can start at 40 but repeat every 10 yearly. What we have seen, average risk we have taken up. It's very easy. Start at 50, colonoscopy 10 years, sigmoidoscopy, virtual colography, double contrast barium every 5 yearly, stool DNA every 3 yearly, FIT or FOBT every yearly we have to do. Now, high risk patient, first category we will take a family history. If suppose patient has a family history positive, then we have to see that is it a first degree relative? If first degree relative less than 60, first degree relative before 60-year age, two or more first degree relative before 60-year age is there, then family history is there, definitely we have to start at 40 because he is a high risk. But if it is a first degree less than 60, we have to repeat every 5 yearly. If first degree, second degree more than 60, then we have to repeat every 10 yearly. Means we have to do first at 40, then we have to continue 50, 60, every 10 yearly we have to repeat. Screening guideline for individual high risk based on genetic. We have seen first category of high risk is family history. Now it is based on the genetic. If suppose FAP patient is very, very clear. Start your screening colorectal cancer at the age of 10 to 12. But initial screening, it can be done with flexible sigmoidoscopy yearly. And if suppose at any point of time he turns to be adenoma, then we have to follow with colonoscopy. HNPCC, FAP start at 10 to 12 with sigmoidoscopy and we have to repeat yearly. In HNPCC, it's start the screening colonoscopy 20 to 25 years and you have to repeat colonoscopy every 1 or 2 years in HNPCC. These patients consider genetic cases if not done genetic testing. In IBD, 8 years after the case of pancolitis, we have to do every 1 or 2 year colonoscopy. If we are having 12 to 15 years after the onset of left-sided colitis, we have to do colonoscopy every 1 or 2 years. Means we are having family history wise 3 category: FAP, HNPCC, IBD. If it is a FAP, start at 10 to 12 and repeat every yearly. It is HNPCC, start at 20 to 25 years, every 1 or 2 years you have to repeat. If it is a IBD pancolitis or left-sided colitis. If pancolitis, onset of pancolitis till 8 years, no risk. After 8 years, every 1 or 2 yearly. If it is a left-sided colitis, till 12 to 15 years, patient is not at the risk of cancer. After 12 to 15 years of left-sided colitis, every 1 or 2 years, we need colonoscopy to rule out cancer in these cases. Synchronous invasive colorectal cancer are found almost 3 to 5%. Why we have to know about synchronous colorectal cancer or synchronous colorectal adenoma, that is 30%. A person is having left-sided cancer we have seen at the sigmoidoscope. Whether we will complete the colonoscope or not, that is a question. If we have found out the cancer at the left side, we have to see right side also if scope is negotiable. Provided scope is negotiable, scope is going across the tumor. Why? Because 30% of one cancer in the colon will have 30% adenoma in rest of the colon. And also there is 3 to 5% of the patient we may surprisingly get the cancer in other side also. For that reason, if we are having One cancer in the colon, definitely we screen whole the colon to avoid that synchronous adenoma in 30%, synchronous cancer in 3 to 5% of colorectal cancers. Complete colonoscopy should be if suppose I am putting the scope and going to the left side of the sigmoid. But scope is not passing because the stricture of the colon. Recently I had a 60-year male. We have pushed the scope, but at the sigmoid it is not going above because cancer is completely obstructing lumen. What's next plan? In those patients, I have to do the surgery. I have to come out. But screening, further surveillance colonoscopy should be done in a 3 month after the surgery so that we should rule out other part of the colon. Is there any other malignancy associated? Synchronous primary tumor have same prognosis as a patient of single site resection. Synchronous, if we are having synchronous malignancy, is this means it is a very poor tumor? No, it is the same prognosis. Metachronous primary tumor arises in 3% in 5 years and 9% in several decades long-term survivals. So synchronous colorectal cancer are known. Adenoma is 30%, tumor is 3 to 5%. Any patient left-sided colon has to be screened complete colonoscopy. We should do complete colonoscopy before taking for surgery. Should not miss another one tumor on right side when we are dealing with left side. At the same time, if we are not able to pass the scope on the time of before the surgery, then diagnose left side and do the CT scan. CT scan, if we are not detecting anything on the right side or transverse colon, go for surgery. But make sure that in next 3 months, completion of colonoscopy should be done to know that proximal colon is not having any adenoma or any cancer. Session of screening. We have started at screening at 50, high risk at 40. Till how many years we have to go? US task force tells that up to 75 years we should continue. After that, no need. Should discontinue fewer than 10 years of life expectancy. Around 75, we should 75 to 80, we should not go. Screening should not be performed in an individual after 85. There is no rule because doing colonoscopy 85, if suppose some complication comes, will be more hazardous than doing screening test. Effort of screening early detection have resulted in significant decrease of colorectal incidence, about 3 to 4% per year over last 15 years. Lifetime risk of colorectal cancer in a men around 5%. Adenomatous polyp. According to WHO organization criteria, the polyp tubular 65 to 80% incidence, villus component is less than 25% and risk of malignancy is less than 5%. If it is a tubular type of adenomatous polyp, incidence is high, that is 65 to 80%. Villus component is less than 25% will be there in tubular. Risk of malignancy less than 5%. If it is a tubulovillus, incidence is 10 to 25%. Villus component is 25 to 75%. Risk of malignancy is 20 to 25%. If it is a villus, incidence is less, 5 to 10%, but villus component more than 75%, which is malignant. Risk of malignancy is 35 to 40% if it is a villus adenoma. Tubular adenoma, incidence is more, 65 to 80%. Component of villus is less than 25%. Risk of malignancy is less than 5%. Tubulovillus, incidence is 10 to 25%. Villus component is 25 to 75%. Risk of malignancy 20 to 25%. Villus adenoma, incidence is 5 to 10%. Villus component is more than 75%. Risk of malignancy is 35 to 40%. Risk of cancer. Tubular adenoma is smaller than 1 centimeter diameter, less than 5% risk containing the cancer. Tubular adenoma larger than 2 centimeter, 35% chance that contain the cancer. If it is a villus adenoma more than 2 centimeter, carries risk of 50% chance of containing the cancer. If it's tubular adenoma less than 1 centimeter, less than 5% contain cancer. Tubular adenoma larger than 2 centimeter, 35% chance of cancer. Villus adenoma more than 2 centimeter, 50% chance of that having cancer. Haggitt's classification for pedunculated. Pedunculated polyps, there is a classification uses Haggitt. For sessile polyp where there is no stalk, the classification uses Kikuchi classification. Haggitt's classification, level 0 is non-invasive, Level 1 is cancer cell invading up to the into the submucosa but limited to the head of the polyp. If it is a level 2, cancer cell invade into the neck of the polyp. Level 3, cancer cell invade into the stalk of the polyp. Level 4, cancer cell invade into the submucosa of the bowel below the bowel wall, below the stalk of the polyp. Means level 0, non-invasive. Level 2 up to the head. Level 1 up to the head. Level 2 up to the neck. Level 3 stalk. Level 4 below the stalk. It is going beyond the stalk. After polypectomy, the Haggitt 1 to 3 risk of spread of the lymph node is less than 1%. For if polypectomy margin is negative, observation is sufficient. If Haggitt 4, risk of metastasis ranges from 12 to 25%. Resection should be strongly considered. When to tattoo after polypectomy? If polyp margin is when all polyps greater than 1 centimeter, recommend tattooing during the polypectomy. Sessile lesion when removed in piecemeal, definitely we need a tattooing. Chemo prevention. Aspirin is used for chemo prevention. History of adenoma in colorectal cancer. It has been found that it will prevent 21%. Means if we are having adenoma, we are resected. If we are going with aspirin as a treatment, we will reduce 21% recurrence. If celecoxib has been also tried, 34% it will avoid getting the adenoma. Calcium intake has been also been shown, hormone replacement also been shown. Aspirin, celecoxib, calcium intake, hormone replacement, and some supplement, folate supplement also been found protective in colorectal cancer. But beta carotene, selenium, vitamin A, C, E are not significant benefit in chemo prevention. Thank you.